I'm Dr. Emily Hill, and I'm a board certified neurologist with additional training in movement disorders. I actually came to visit University of Cincinnati like almost 15 years ago, and I totally fell in love with movement disorders. There were so many people with Parkinson's disease who said, please become a Parkinson's doctor. We need more of you. And they encouraged me, and I totally did it. I went to medical school and came back now as a movement disorders doctor, and I'm also a part-time researcher. So I do research and I see patients, and I really, really enjoy it. So I think this is an important talk. I'm really glad to be here. These are things I wish I could tell all my patients, and I just don't usually have time to go over all these things. So I think this is a great idea to do a presentation like this. So today I want to talk a little bit how doctors think about Parkinson's disease. We might need to mute some more people. That will include a little history or a little bit about what they tell us in medical school about Parkinson's disease. I'm going to discuss how we make the diagnosis of Parkinson's, because unfortunately, it's not like a lot of other diseases. And then I'm going to talk a little bit about symptoms and a little bit about treatment. Okay, next slide. We always start when we try to get money from the government, for example. Whenever you talk about Parkinson's disease, the first thing we tell everybody, it is super important. Parkinson's disease is a growing problem and it's very common. 1 in 100 people over age 60 have Parkinson's disease. By the time you get over 85 years old, it's 5 in 100. So it's very, very common. And you can see here as the population is aging, the number of people with Parkinson's disease is going way up. So this is a huge, important problem, and we need to be working on solutions for it. Next slide, please. So the history of Parkinson's disease is kind of interesting. This was in the 1800s, just outside of London. James Parkinson was looking out his window and saw a few people who had a particular syndrome that seemed to have similar symptoms. So they had a little bit of poor posture, they had some shaking, they had some trouble walking, and he saw 3 people out his window, and then 3 other people he was able to examine. And with this, he said, I don't know what this is, but they seem to all have the same syndrome. They all have the same disease. And so I think that is, that's the very early beginnings of Parkinson's disease. And next slide, please. When you look at the brains of people who have those symptoms, they had some things in common. So importantly, this is the brain stem on the left there. They're showing the brain stem. That's a side view of the brain. And there's one part of the brain that tends to look different in people with Parkinson's disease. So this is the substantia nigra. Those are cells that have melanin in them, the same melanin that gives skin color. And you can see there are fewer of those cells, and you can see that by the loss of color there in Parkinson's disease. So those cells have died in the brainstem. And so that's one of the hallmark features of a brain with Parkinson's disease. The other hallmark feature is this pink bubble here that you'll see to the right. There's an arrow pointing to that little pink round thing. And that is a Lewy body. So that is something that should not be in that cell. That little brown stuff is the melanin, and then the rest of the cell looks okay, but that pink bubble shouldn't be there. We don't know how it gets there. We don't know what it's doing, but we know that people with Parkinson's disease have those pink bubbles in their cells, and that is not normal. Okay, next slide, please. The primary problem in Parkinson's disease is a dopamine deficiency. So you see here, there are 2 brain cells talking to each other, and the chemical that they're using to talk to each other in these little dots are dopamine. Now, people think of dopamine as like a pleasure center or a happy chemical, and that's true in other parts of the brain. But in the motor part of the brain, in the brain stem and its connections to the deep structures of the brain, dopamine is a motor chemical. So it helps with smoothness of movement. So the primary problem is, of course, a simplification, but the primary problem in Parkinson's disease is we're low on dopamine. Next slide, please. What causes Parkinson's disease? We do not know. That's the short answer. We know that it's a combination of genetics and environment. I'm not sure if there's more text coming up on the slide there. But we know that, oh yeah, so it's a combination. We know that a small number of people have a genetic cause. So this picture here, this is Roy Alcalay and a couple from University of Columbia. So he studies people of Ashkenazi Jewish descent who have certain genes that tend to run in their family that can cause Parkinson's disease. So that's not as common, maybe 10%. Closer to 15 or more have some family member with Parkinson's disease. So the genetics of Parkinson's disease is quite complicated. I'm giving a talk on that at the Sunflower Symposium. So hopefully some of you or all of you could attend that one because I really enjoy that topic as well. But we also know there's some environmental factors. And maybe if there's more text that comes up on the slide there's some certain pesticides that have been associated with Parkinson's disease. We know that Agent Orange exposure has been associated with Parkinson's disease. Manganese welders have a very high rate of Parkinson's disease. So some people say that the way you can think about this combination of genetics and environment is genetics loads the gun and environment pulls the trigger. So you had some predisposition for Parkinson's probably, and then there was some trigger from the environment, including an infection or some exposure to something that brought on the symptoms. Next slide, please. Okay, now, how do you make the diagnosis? People say to me, how do you know I have Parkinson's disease? For me in the clinic, it's a two-step process. I hear, quote unquote, the Parkinson's story, which I'll tell you about. Then I confirm the diagnosis with just the physical examination. So these are the accepted Parkinson's disease brain bank criteria. So when they studied a bunch of brains with Parkinson's, they said, if you have these things, you have Parkinson's. These are the diagnostic criteria. So when I'm listening to the story, I'm listening to the symptoms, I want to hear someone had the symptoms start on one side. And even if they go to the other side, they tend to always be worse on that original side where symptoms started. The decreased smell, constipation, acting out a bad nightmare, rest tremor. You don't have to have rest tremor, but when you hear that, you think, okay, this is something I'm thinking about. And then if someone has tried the medicine, the levodopa, and they've had improvement, that supports a diagnosis of Parkinson's. And anybody who's had over 10 years of symptoms, there's very little that does that, that will give you, a long duration of symptoms of Parkinson's disease. Now, when I'm asking the questions, I'm looking for Parkinson's lookalikes, or these cousins of Parkinson's disease. Maybe if we click again, those will come up for me there. Yeah, so and it looks like I might need more clicks. There we go. Okay, so other questions I'm asking, I'm looking for Parkinson's lookalikes, things that also cause slowness, stiffness, and even tremor, but aren't quite Parkinson's disease. We call those Parkinsonism. So I also tell people it's Parkinson-ish. You got a couple of the symptoms, but you have some other things. And these tend to have different problems crop up. They tend to have different speed of progression. So that's why we make the distinction there. So these are like dementia with Lewy bodies, multiple system atrophy, progressive supranuclear palsy, and cortical basal syndrome are some of the top Parkinsonisms that look like Parkinson's but aren't quite. And then I'm also asking, very rarely you can have damage to the brain that can mimic Parkinson's. So if you have strokes in just the right spot, a history of a really bad brain infection that caused damage to the brain, rarely a tumor. I've seen a patient who had a really big tumor that was squishing the part of the brain that's involved in Parkinson's. And I thought they had regular Parkinson's till I looked at their brain. And unusual, a spinal fluid leak where the brain gets kind of saggy, you can have symptoms that look just like Parkinson's. So that's when I meet a patient, I hear all the symptoms and I check for these other things that are Parkinson's lookalikes. And then the next thing I do is I examine them. And so the first part of the exam is super important. The finger taps, the open close, and the move the hand back and forth. I do those because to make a diagnosis of Parkinson's, you must have a certain slowness of movement. So your finger tapping is not quite as big and it doesn't stay as big and it's a little bit slow and jerky. That is required to make a diagnosis of Parkinson's disease. Then you need at least one other thing. So a certain stiffness of the muscles, that typical tremor at rest, that's 4 to 6 times a second is the movement, and then a problem with balance. You'll notice rest tremor is not required. So if you have, for example, slowness of movement, and rigidity, you meet the diagnostic criteria for Parkinson's, provided you pass the first test, which is, did you tell me the typical story and nothing else made me think it was a Parkinson's lookalike? Okay. Now, rarely after I examine the patient, I'm not sure. Let's say they have horrible arthritis, or I've had a patient who was missing an arm and I couldn't tell for sure. I've had a patient who had horrible spinal cord injury in the past, so they had other reasons to have some of these symptoms. I say, I can't say 100% sure. Or another one, if you've had tremor for decades, there are people who have had a little bit of tremor since they were teenagers, and maybe they have a little bit of slowness, and it's either early Parkinson's or it's just tremor. Then I move on to this thing called the DAT scan. This is a scan that marks the cells that are unhealthy in Parkinson's disease. It's a little nuclear tag. And so you'll see here that in somebody who has a healthy brain, the colored part deep in the brain there is nice and bright, versus somebody with Parkinson's disease, you've lost some of the cells that are projecting from the substantia nigra, and the color is decreased. So that confirms to me that this person is low on dopamine. It doesn't always tell me, they could still have one of the Parkinson's lookalikes, but they definitely have a dopamine deficiency when they have this. So we don't usually need this when we meet somebody with Parkinson's, but in those rare cases, it can be helpful. It's an expensive scan, and it's not more accurate than hearing the story and doing the physical exams. We don't use it all that much. Okay, and then the next slide. Okay, so now what? You've been told you have Parkinson's disease. What do we do now? So usually the next question people ask me, they say, what stage am I? And I have to say, no. Parkinson's doesn't have stages like cancer. And people want to say, I want to know what stage. The stages, quote unquote, are really just used for research purposes. And if you click one more time, there's a little figure at the bottom there. It's really just based on how much walking trouble you have. So do you need a cane or not? Do you need a wheelchair or not? Please don't get hung up on the stages. That's not how we use them. Okay, so then the next slide. So what you're really asking, I think, when you say what stage am I, is what can I expect? What's going to happen to me? And we say, we don't know. Everybody's different. And that is so, so important. I have to stress that. There's no two patients with Parkinson's disease who are alike. So one of the reasons I really enjoy taking care of people with Parkinson's, but it can be frustrating because, we don't have a crystal ball. We can't tell you what to expect. So please remember that. But we can talk about ideas. We can talk about trends. We can talk about what we tend to see for people. So this is really important. If somebody has Parkinson's disease, and at the time of diagnosis, they have pretty normal thinking and memory, and I don't count like you can't think of the right word. That's part of Parkinson's. Or if you forget somebody's name, okay, excluding that, if you have pretty normal thinking and memory, the life expectancy is normal. So the person with Parkinson's disease will pass away at the same age as somebody who does not have Parkinson's disease. Okay. Now symptoms will crop up, and I'm not going to sugarcoat that. Symptoms crop up as the disease progresses. I think it can be a little frustrating when doctors don't bring this up, right? That, when you get into 10 plus years of symptoms, you're going to have more trouble. We have strategies to deal with all these things. Okay, so that's really important to remember. But the majority of people with Parkinson's disease eventually develop some memory problems. And so I don't tell you that to scare you, but it is, planning for the end of life is part of aging, and it's certainly part of Parkinson's disease care. So those are some things that we talk about when we talk about progression. Okay, next slide. Okay, one of my favorite things about Parkinson's disease is it is super treatable. So my favorite treatment for Parkinson's disease is exercise. Cardio protects the brain. Cardiovascular exercise increases chemicals. Let's see. Hopefully you can all hear me. I hope we didn't lose anything there. Maybe go back one slide if you would. Awesome. Okay. So cardiovascular exercise, getting the heart rate up, increases chemicals that protect your brain. So this is down here, the bar graph. You see the black and white bar in the bottom left. This is a study in Parkinson's disease patients who did a regular exercise program, and this is a measure of the chemical that protects brain cells. So it goes up in the bar to the right there, in the black bar, showing that their brains were protected. Okay, so this is medicine for Parkinson's disease. And then in the graph over here to the right, you can see, thank you. This is a clinical trial where we did exercise in Parkinson's disease. This was treadmill exercise, and it was testing different intensities of exercise and looking at how the symptoms changed. So when I do the finger tap and the open close and all that stuff, I give that a numeric score. The numeric score improved in people who did intense cardiovascular exercise. Okay, so we're slowing the progression and protecting the brain when you get your heart rate up. So then that's the recommended rate. It's 30 minutes a day, 5 days a week is what they did at the high intensity. So people ask, what kind of exercise? I say, I don't care, as long as you like it. Please try to find something that you like. I'm partial to the exercise that gets the heart rate up, but I recognize that that's not easy to do. So do something that you like. Customize the program. You guys know about Rock Steady Boxing. The recumbent stationary bike is for people with balance problems to help them feel safe. And swimming is great. Again, we don't have the balance issues. Parkinson patients have decreased range of motion in their shoulders, and that can cause a lot of problems. Sometimes that's the first symptoms. I had a shoulder problem, and they thought it was from an orthopedic issue. And I said, no, that's because you don't swing your arm well when you walk. So any kind of exercise that gets the heart rate up is good. An ideal program will include stretching and strength and all that, but work up to that and customize it. Okay. Now, the next favorite treatment is replacing the dopamine. So I brought this figure back again so you can see the chemical that is low in Parkinson's, the dopamine. You can just give it back. So we can give it in a pill form. The pill form of just replacing the dopamine there used to make everybody throw up. So they customized, they figured out how to fix it, and they added carbidopa to the levodopa. Levodopa is the active ingredient. Carbidopa just makes sure you don't throw up. So these little yellow pills are the immediate release, just replacing of the dopamine. And that improves almost all of the symptoms of Parkinson's disease. Okay, and then just to mention a couple other ways of getting that levodopa into the body. Rytari is a newer form. One of the issues with Sinemet, or short-acting carbidopa levodopa, is it wears off. So you got to take it at least 3 times a day. And as the disease marches on, you're going to have to take it multiple times a day. So we're always looking for new ways to prevent this, just taking pills all day, every day. So Rytari was a capsule that includes a short-acting and a quote-unquote long-acting Sinemet. Now that didn't work out great. The Sinemet CR, we wanted to increase the interval between doses, but for some reason it just didn't work. It interacted with food, and sometimes it wouldn't kick on at all. But if you put it in a capsule with the immediate release, it helps a little. You still have to take it at least 3 times a day, unfortunately. But one of the reasons I like it is it has a lot less side effects. It's a real gentle carbidopa levodopa. So my patients who have side effects on regular old Sinemet, I put them on Rytari. Now the levodopa gets in the body in the first part of the intestine. So you can just put the gel, you can make this carbidopa levodopa concoction gel that it sits in a fanny pack kind of, and goes into the intestine, just slow infusion all day. So these are people who are taking pills way too much. We look at that option. And then some other types of medicines that can help with dopamine. The dopamine agonist, that's your Mirapex or Pramipexole, your Requip, aka Ropinerol, Nupro patch, you've heard of these names. These pretend to be dopamine. So if you look at the little blue button-like things on the cell, that's getting the dopamine. Yeah, exactly. Thank you. The dopamine agonists sit right on those buttons and make the cell think it got dopamine. Okay, so that can be pretty effective. They're very good anti-tremor medicines, but boy, do they have side effects. So they make people sleepy. They, cause compulsive gambling and addiction sometimes. So I'm really, really careful with those. But some people love them. Some people swear by them. So if you don't have side effects, we use them. And then just down here, just for sake of completeness, there are a couple of other classes of medicines that will boost dopamine. So your selegiline or your rasagiline, those will help keep your body's own dopamine around. It keeps it in between these two cells here rather than getting recycled. And then you may have heard of entacapone. That is another dopamine booster that keeps the Sinemet around, prevents your body from breaking down the Sinemet. Okay, so those are some dopamine meds. So levodopa tips. Everyone asks me, what about food? Does it interact with food? And so my first point is don't worry too much about that. If it ain't broke, don't fix it. If you're getting good benefit from your medicines, that's totally great. Now, if your levodopa isn't working very well, or you have a dose that doesn't kick on for some reason, and you never felt it work for you, it could be that it's competing with a high protein meal. So some people tell me if I eat a steak, my Sinemet doesn't do anything for me. So, okay, well, try to ease up on the steak, especially if you have to move around afterwards, because protein can compete with levodopa a little bit. Now, I mentioned before, levodopa is absorbed in the duodenum, the first part of the intestine there. So ideally, you take your medicine on an empty stomach, you get it through the stomach into that first part of the intestine, and then you eat about a half hour later, and that keeps the Sinemet where it's meant to be and helps it kick on ideally. But if this causes stress, or if this is hard, and you're getting good benefit, don't worry about it. These are just some pro tips for levodopa getting into the system. One of the major things I do when I meet a new patient is I really scrutinize the timing of the medicine. I say, what time you take your levodopa? If you take it morning, noon, and bedtime, I don't like that because the medicine works during the day. So you want it to work while you're up and moving. It's a symptomatic treatment. So I don't love bedtime doses. Of course, sometimes we use that Sinemet CR that doesn't work great during the day. Sometimes we use that at bedtime, but that's the short acting we like to use during the day. So that's a little tip I usually give people. Okay, what's our next one? Okay, levodopa myths. So these are some, there are multiple. So some people worry that they could get addicted to it. And some people worry because levodopa is quote unquote the big guns. So people are worried, if I use it now, is it going to stop working for me in the future? Okay, and then I think there are a couple other ones. Okay, and then a lot of people are worried about levodopa because it can cause these wiggly movements. We call dyskinesia. So this is a complicated slide, but where I want you to focus is on the right, that these little bars here. Thank you. So this is an excellent study that came from Dr. Espay here at UC and his mentor, Tony Lang, who's a huge name in the field. This was looking at the benefit of starting levodopa early for Parkinson's disease, because people have levodopa phobia. I don't want to start it for all those reasons on the last slide, right? So they delay, and then they start the levodopa when they feel like the symptoms are bad enough. That causes more disability. So that's those bars on the right there. If you wait too long to start the levodopa, overall across the lifespan, you cause more trouble. It's just harder to get around, it's harder to move, and it wasn't worth waiting. Okay, so they did this study that kind of put that to bed. Now, there's also the brain surgery for Parkinson's disease. A lot of people ask about this. This is a small number of people with Parkinson's disease who qualify for this surgery. Now, this, I like to think of it as the surgery substitutes for the medicine. So for people who are taking the pills all day, every day, and they every couple hours need the carbidopa levodopa, the surgery can replace that and it'll reduce how much you need to take pills. Another time we think about this treatment is somebody has really bad tremor and the medicines just don't touch it. Sometimes the surgery can help. So it's a little electrode that goes deep into the brain and it stimulates the target of the substantia nigra. So substantia nigra projects cells to the deep part of the brain. So it kind of, interrupts the abnormal circuitry so that it allows to kind of pretend like there's medicine in the body at all times. Okay. You're usually awake for the surgery. And so we can test things. We can have you tap your fingers and open, close, and make sure that we're in the right spot and using the right settings. But people who do well with the surgery do very well. and they oftentimes can reduce the amount of meds that they need. It doesn't treat other symptoms usually, just it treats things about as well as a levodopa. Now, Parkinson's is a complicated disease. It affects all kinds of body systems. Doctors like to talk about the motor symptoms, the tremor, the slowness, all that stuff. We kind of get partial to that because we like to treat those. We have a good list for how to treat motor symptoms, but we have to think of these non-motor symptoms a lot too. So I really encourage patients to keep lists of the non-motor symptoms. So by that, I mean depression, anxiety, fatigue, sleep problems, not wanting to do anything, urinating too frequently, constipation, all this kind of stuff. People are worried it's the medicine. No, if you're thinking, is this from my Parkinson's? The answer is probably, because this is a complicated disease. Now, rarely we'll say, okay, go to the primary care for that one. But very, very often, the things that ail our patients are related to their Parkinson's disease. Okay. So keep track of these ones and ask your doctors about them. All right, now this is, just to tell you, we have all kinds of strategies for these. So this is why I want you to keep a list and bring them to your appointment, because I can help. I have lots of things I can do. Some of them are pills and some of them are not. Okay, sleep is super important. So you're going to have to be a health nut to get good sleep. You got to do sleep hygiene, which means you have a set bedtime and a set time that you wake up and things like that. So we don't have to go through all of these, but just this purpose of this slide is to tell you I have strategies for these things, and we can work on them together. Okay. Now we got to make sure that the care partners are well taken care of too. And this is another place where doctors can fall short. We don't always ask these questions, but these are some good tips from prior presentations. You got to make sure that you take time for yourself. You got to make sure that you're looking for what you need help with, because if you're not thinking about it, if you're not making a list of what you need help with, you're not going to get the help. And so, the concept of identifying stress triggers, I think, is really important nowadays. I think, there have been times where we're looking at the news and thinking, oh, I don't feel stressed. I can look at this, but your body's telling you, no, you are stressed. So make sure you're keeping track of what gets in the way of your well-being too. And I think there's another slide on this. It's important to process. Everybody's going through something differently. Keeping it all inside is not helpful. It really causes problems. And then looking at getting breaks, looking at taking care of yourself as well. And we have resources to help with this too. We have the Council on Aging can be really helpful, and people can qualify for more than they think. So we have an excellent, excellent social worker, Becca Irwin, who helps our patients with these kinds of things and their care partners as well. Okay. We are doing some awesome research at the University of Cincinnati. And it's one of the reasons I came back to University of Cincinnati. One of the projects that we're most proud of is the CCBP, the Cincinnati Cohort Biomarker Program. This is a picture of Dr. Espay and Ben Setcher, who's a patient, and they recently published a book that they co-wrote called Brain Fables. And Espay is a total thought leader in the field. We are rethinking what we know about these diseases. I've just gone through how we make the diagnosis, what we know Parkinson patients have in common. There are so many things that are unique from patient to patient, and we need to be rethinking how we think about that. There's no blood test for Parkinson's. That is totally unique to this field. I mean, every other field of medicine has lots of blood tests and other ways to track what is going wrong in the body and how to fix it. And we don't have that for Parkinson's because everyone's so different. So whenever we try to find one blood test that fits everybody, it's all over the place because everybody has different Parkinson's. So on the next slide here, their strategy, what we're doing now is we're collecting as much information as we can on everybody. So anybody who's aging is invited to this study. And we're going to do all kinds of tests in all kinds of body fluids and see who is an outlier, who has a very high or a very low level of a certain marker. And then later on, ask if that caused symptoms. Maybe somebody with Parkinson's disease and somebody with one of the cousins or Parkinsonisms, maybe they have a similar chemical profile in their body, but their symptoms are different. So that's looking at it backwards than how we have been looking at it. And we're very, very proud of this project. And I think we're a little over 200 patients now, or participants, I should say. We're including healthy controls. And now that we have less restrictions with COVID, we're really doing a lot of work here. Okay, it's very exciting. Now, I always encourage people, if they're interested in clinical trials, we're not doing a ton of clinical trials right now in Parkinson's disease. The hot new clinical trials are in genetics. So genetic forms of Parkinson's are trying certain treatments for genetic forms of Parkinson's. And then the other trials are really looking at all kinds of new ways to develop dopamine delivery systems. So what else can we do besides pills and the gel and the DBS? So, but I tell people to check in on clinicaltrials.gov periodically. You just type that in and you type in Parkinson's and you hit search, and maybe there'll be something that you would qualify for, that you could even travel for to be part of a clinical trial. And of course, we, are a big site for clinical trials here, and we do clinical trials too. But we're hoping that from our CCBP project, we'll be able to develop very effective clinical trials in the short term, hopefully in the coming years. Okay. So that is what I have. I want to hear your questions. The way we're doing this is through the chat. So type some questions into the chat and I will read them. And I think I have like 10 minutes if I got that right. And so I will read our first one. Cheryl says, I heard that there's a new swab test coming out to diagnose Parkinson's. Where are they in the process? Swab test, I'm not sure how far along that one is. There is a skin biopsy that everyone's pretty interested in. So they take a little piece of your skin and they look at it under the microscope and they show, like, remember that little pink bubble, the Lewy body? They can show things like that in skin cells that they grow in the lab, and they can show if there's signs that there could be Lewy bodies in the brain from that. So that is an interesting one. Again, for some of these people who were on the fence, is there a possibility that this is not Parkinson's? Oh, okay, so this is interesting. The skin test in the UK based off the smell given off by people with Parkinson's disease. That was a great story. There was a woman whose husband had Parkinson's disease. And she said, I swear I could tell when he got Parkinson's disease because the way he smelled changed. And we said, are you serious? And they did a trial where they had sweaty t-shirts from people with and without Parkinson's. And they had her smell them in a blinded fashion where she couldn't tell who was who. And they said, which of these people has Parkinson's? And she was super accurate. So then they looked at what on the skin that can cause a smell, so meaning it's something that can become like a gas, is different. And so they're developing a test from that. So yeah, I'm curious to hear as well if someone else knows where they are at with that, in terms of becoming a diagnostic, and we can use clinically, that'd be great. And Mary says, does levodopa enhance or impact delusions/hallucinations? Can that be controlled with dosage/frequency? That's a great question. Yes, levodopa does enhance. I like the way you said that. Delusions or hallucinations. So these are delusions and hallucinations can occur in Parkinson's disease. So that's seeing things usually, sometimes hearing things, but usually seeing things. And delusions are false beliefs. It's usually like a suspicion. I don't trust you. I don't know if you're the real you. I don't know if this is my real house. I think there's people outside. So, okay, those can happen either way, or those can happen with just in Parkinson's disease. But when you add levodopa, it can worsen them. And so usually you're right. The first thing I do is I reduce the dose. Oftentimes we get in a little struggle because then the motor symptoms can worsen. So then I add a medicine to control hallucinations and delusions first, and then I slowly work with the dopamine as well. So hopefully in the combination of treat the hallucinations and gently reduce the levodopa, we can control those things. And Bill says, am I supposed to take medicine at 10 p.m.? That's bedtime. I said, I don't love bedtime. I For people who have off symptoms overnight, so you go to bed, but then you wake up at 3 a.m. because you're stiff and you have to go to the bathroom and you can't move too well, we use the Cinemet CR at bedtime. But if you're someone who takes your levodopa 3 times per day just to move well, the 3 times per day should be waking hours. So it's usually around meal times. So the breakfast time, the lunch time, and around the dinner time. And then as you're wearing off, then you go to bed. Because levodopa can be activating, it can wake you up a little in the short-acting version. So you just want to be careful. I prefer not to do bedtime doses for that reason, unless we're having overnight off. We need a strategy for that. Steve says, do CBD products help? It's a great question. So CBD is a sort of medical marijuana. Medical marijuana includes CBD and THC. Okay, so CBD is not the drug part. THC is the part that gets you high. CBD is not. Okay, I'm sure many of you have been interested in this, but just to make sure we're on the same page. CBD was approved as a dietary supplement recently in the last few years or several years. So it's available over the counter. Okay. Now the doses they use are pretty low over the counter. I'm very cautious with it because it's not very well regulated. Okay. So there's that. I'm learning with my patients about CBD, honestly, because we haven't had a lot of good research on CBD. Some people tell me it helps with anxiety and it helps with sleep. And I say, okay, as long as you're careful and you trust where it came from, keep reporting back to me. Now, CBD was approved for a certain couple of seizure syndromes. So little kids who have very, very bad epilepsy, they use super high doses of CBD to treat their seizures. So people wonder, can other neurologic syndromes benefit from CBD then? So they used that same dose in a very small trial in Parkinson's patients, and it didn't go well. Everybody had side effects. There was a lot of diarrhea. The liver enzymes went high, but people slept better. But it was not placebo controlled. And there's a very prominent placebo effect in Parkinson's, which we can do a whole talk about at some point. But the answer is it might help a little bit. Please be careful. No THC, please. Okay. Could you explain again what carbidopa does and levodopa? So, okay, levodopa is the active ingredient. This is the way that you replace dopamine, is you give levodopa. Carbidopa is its partner that comes with to prevent nausea. So carbidopa is not active. Levodopa is the active drug. And when you combine them together, it just prevents nausea. So that's why the pill contains the two together. Very rarely, if somebody has way too much nausea, I'll add an extra carbidopa pill. It's not active, it doesn't treat Parkinson's symptoms, but it couples with levodopa to prevent nausea. Okay. Are there any studies that support using puzzles or other brain teasers that can help with cognitive functioning? Yes, that's true. And this is true for any syndromes that cause memory problems. Keeping the brain active has been shown to be helpful. There's not a particular type that we recommend, but this is among the recommendations to keep, to ward off dementia. It's exercise, it's, stay active as much as possible, stay socially engaged, try to keep having friends and doing stuff with people when they withdraw from friendships and from interacting with other people, they don't do well. So all those things are together with, but for me, exercise is number one, because I have a chemical proof that will protect your brain. Okay, these are good questions. Anybody else got any? Thank you so much for clicking through my slides. I'm so sorry that didn't work for me to share them, but you did such a great job, and you're as my pointer as well. So I really appreciate that. I hope you guys enjoyed the talk.
Thank you, Dr. Hill. That was very helpful, and I'm actually kind of glad that I ended up with the the slideshow, because I may in a few minutes go back to one of your slides, the slide that showed Dr. Espay and Ben Stetcher, and part of the reason that I might bring that up is that we have our spring forum, much like the Sunflower Symposium. Our spring forum is in about 3 weeks on April the 10th. And Dr. Espay and Ben are going to be presenting. They'll talk about their book, Brain Fables, and they will also, Dr. Espay is going to update us on how things are going with the Cincinnati cohort biomarker project. So the protocols. So thanks for that little commercial that you gave us right in the middle of your presentation.
Good.
Again, we want to thank Dr. Hill for joining us. I know so many of us don't get a chance to spend 45 minutes or an hour with the doctor, multiple opportunities to ask questions. So again, thank you very much.